Dr. Emma Mohr from the Division of Pediatric Infection Disease here at UW, and she will be talking about COVID care in pediatric populations. So thanks for joining us, Emma, and I'll turn it over to you.
All right, great, thank you. So as he said, I'll be talking about pediatric care with COVID here in this pandemic, and a lot about the knowns and the unknowns in this disease. So I'm going to start by talking a little bit about the outlines and the goals for this talk. So I want to talk about the symptoms of pediatric COVID disease, how it's transmitted, how we manage it, some about the epidemiology, and then a lot about how we think about infection control in pediatric settings. And of course, all of this is related to pediatrics. I don't pretend to know anything about the adult aspect of this. I'm going to start with a case presentation that we had in our hospital system. This was a 5-week-old infant who presented to the emergency room with a temperature of 100.5 degrees Fahrenheit. This 5-week-old infant had a 2-week history of some congestion, just a little bit snotty, but not any frank rhinorrhea, and a little bit of increased fussiness that day. On exam in the emergency room, the baby was active and had a normal appearance, comfortable work of breathing, normal breath sounds. Tympanic membranes were normal, and the baby didn't have any observable rhinorrhea. They decided to get labs on the baby and found some leukopenia with a white count of 4.6, 31% neutrophils, 40% lymphs, and unremarkable urine analysis. CSF that showed a little bit of protein in the CSF. Nucleated cells were only 7. This baby was given a dose of ceftriaxone and admitted to the hospitalist service here. Because this was during the coronavirus outbreak, they called to ask whether they should test the baby for coronavirus, and we said yes. This was back when testing was really limited, and we only tested patients who were going to need aerosol generating procedures. And with the history of rhinorrhea and a 5-week-old and potentially needing suctioning, we said, yes, it sounds like a good reason to test. It turned out that the PCR test was positive. All the cultures done on the baby, the blood, urine, CSF, had no growth. The baby had stable respiratory status throughout its stay, a little bit of increased stool output, was breastfeeding well, and then discharged home the next day. So we recommended isolation precautions for all the household members for 14 days to limit spread of this virus. This case that we had in our hospital system really exemplifies the symptoms that we see in pediatrics. So the symptoms largely are milder than adults. In case series, when they look at the symptomatology of a large group of pediatric patients, they find fever in 1/3 to all of the patients, cough about in the same proportion. Few kids have rhinorrhea or sneezing. Some kids have sore throat, even less have headache, diarrhea, or dyspnea, and some kids have skin manifestations. This virus, as you know, is spread person to person by respiratory droplets and contact. The incubation period is about 2 to 14 days. We can start seeing RNA detected in the nasopharyngeal swabs about 4 to 48 hours after symptom onset. And RNA can be found in the stool sometime after 3 to sometimes over 30 days. We think from studies done by our Chinese colleagues is that most children are infected from family members. But I think there's a big caveat in this, is in that these studies are done during this time of social distancing. So kids really don't have outside exposures. And so of course we're going to see it come in from the family members who are the ones on the front lines or working in the grocery stores, etc. So the clinical course in pediatrics ranges from asymptomatic to critical cases, with most of the kids falling in the range of either having a mild pneumonia or acute upper respiratory tract infection. So some kids are asymptomatic, some kids have severe pneumonia, and a very few have critical case. And this critical case is what they're talking about with the respiratory disease. On the bottom, you can see some lung CTs that show the ground glass opacities that are similar to the adult findings that we also see in children. It is very common in kids to see co-infection with other respiratory viruses. So finding another virus does not rule out that the child does not have COVID-19 infection. The outcomes for children of a typical course of infection um, presents where children usually have a fever for 1 to 2 days, sometimes up to 8 days. In these children with a typical presentation, so acute URI or mild pneumonia, CBCs are mostly normal, CRP is maybe normal or temporarily increased, and symptoms usually resolve in a week. The less common presentation or outcome is that critically ill patients have respiratory disease. And these are usually children that have some sort of underlying medical condition like congenital heart disease, chronic lung disease, or immunosuppression. Now we're finding a new late manifestation called pediatric multisystem inflammatory syndrome. And I'll spend some time talking about this as well. So something that you may have seen in your practice or heard about in the news is an entity called COVID toes or chilblains. People are finding an increased incidence in chilblains both here and in other countries. And this presentation is an erythematous to purpuric macules and violaceous swellings located on the toes, feet, fingers, and hands. And these pictures show some of these uh, swellings or COVID toes, as people call them. In a case series from Spain, people found mild respiratory symptoms in half of the patients who had these Chilblains lesions. And these respiratory symptoms occurred about 14 days prior to onset of these skin manifestations. They did coagulation studies in these patients and they were normal, and all the patients had these lesions resolve without intervention. In this series of 19 patients, they did PCR, COVID-2 PCR, and found it in one of the one of these Chilblains patients. So far, the serologies for these patients are unknown. They didn't test that in this case series. And I know in our institution for the Chilblains cases that our pediatric dermatologists are seeing, serologies are just starting to now be available. So we haven't seen results of serologies in these patients here in Wisconsin yet. So this is a potential finding. It may or may not be related to COVID, but it looks temporally associated. All right, so something that is definitely in the news now, something called pediatric multisystem inflammatory syndrome. So this is making headlines. It's called an inflammatory syndrome that could be linked to COVID-19, hospitalizing children across the country. And this sprang out of a notification that the UK sent out at the end of April. They were finding an increasing number of pediatric patients who had persistent fever, inflammation, organ dysfunction, and other specific clinical and laboratory features not attributable to other infections. Here in the US, we've found cases on the East Coast, some in the Midwest and South. The article that I was looking at didn't report any on the West Coast yet, and there haven't been any cases reported in Japan or Korea yet. So what is this? The case definition that people are using in registries trying to track this is that children have persistent fever, inflammation, and organ dysfunction of one or more organs. You'll notice this overlaps a lot with the disease criteria for Kawasaki disease. And so these children may fulfill all or partial criteria for Kawasaki disease. Other microbial causes have to be excluded, including bacterial sepsis, toxic shock syndrome, and enterovirus myocarditis. When people look at COVID-2 testing, PCR testing may be positive or negative, and antibody testing is sometimes, but not always positive. The outcomes so far that have been reported in the news in our country is that some death has been documented, but it doesn't happen in all the cases, and so the mortality rate is really unclear. Something new that was just published 24 hours ago from a group in Italy. looks at a retrospective cohort study of children with Kawasaki disease or Kawasaki disease sort of common features from prior to coronavirus and then since coronavirus happened in their town. So you have the group from 2015 to 2020 prior to COVID and then after February 2020. And they found in their hospital 19 patients that fit their diagnostic criteria for Kawasaki disease before coronavirus and 10 after coronavirus started. So they did COVID-19 testing in the group that had 10 patients. They found 8 of 10 patients had positive serologies, and 2 of 10 had a positive PCR. It's unclear if some patients had a positive PCR and serology, or if that's really all the patients, 10 out of 10 from their manuscript. The disease incidence shows a much higher incidence of pediatric multisystem inflammatory syndrome, aka something that looks like Kawasaki disease, after coronavirus entered their town. The mean age is also higher, 3 years compared with 7.5 years after coronavirus happened. And then a lot of the findings of Kawasaki disease, so cardiogram, Kawasaki disease shock syndrome, also something macrophage activation syndrome, a need for adjunctive steroid treatment. These were all higher after coronavirus was circulating in their town. Fortunately, all of the children in both groups responded to treatment. So this is really the first publication on pediatric multi-system inflammatory syndrome, and we should expect a lot more coming to pediatric journals soon. Now I want to jump course a little bit and talk about the clinical course that we see in neonates. So from China that looked at neonates who were born to corona-positive moms that had positive nasopharyngeal PCRs. So of 33 neonates who were born to positive moms, 3 of them had positive NP swab PCRs. And so the incidence of neonatal infection looks like it's about 10%, at least in that cohort. Of those 3 infants, 2 of them had mild disease. They experienced fever, some lethargy, um, radiographic findings of pneumonia, and recovered within a week. The disease was considered severe in one of the 3 infants, and this infant also was born prematurely, had respiratory distress, and bacterial sepsis documented. So they're not sure what portion of this was from coronavirus and what was from the other comorbidities of this infant. So now I'm going to talk about testing recommendations. In pediatrics, it's very similar to adults. In our hospital system, all inpatients are tested with a PCR test upon admission. Outpatient testing is done at physician discretion. I know we are talking about really increasing testing, and this is challenging because as far as I know, there's still just a single site where you can get tested as an outpatient, and so patients from around the region and outlying towns around Madison have to drive to the single site. And that's really challenging when you have families trying to borrow cars to get their kids tested. And I know there's talk about how to increase testing in outlying clinics. Antibody testing has also just become available in our hospital system as well. So this is also positive to do, also possible to do. All right, so how do we manage this clinically in pediatrics? Well, as with adults, supportive care is the first line therapy. There are no FDA approved antiviral medications for this. Um, there is plasma therapy for adults that was initiated at UW, and this rolled out plasma therapy trial last month. We as an institution are developing pediatric guidelines, some national, they call it a guidance document, not guidelines, um, say that remdesivir or convalescent plasma may be considered on a case-by-case basis for severe coronavirus cases in pediatric patients. But they still support that supportive care is the recommended first-line therapy. And there are no trials that I'm aware of looking at sort of post-exposure prophylaxis of any of the reported drugs for pediatric patients like there are for adults. A big question comes up with how to manage children with asthma. And so an allergy group out of Europe actually developed guidelines for children with asthma because I think there's some concern about whether it's safe to still give steroids in children with asthma for acute exacerbations or whether they should still be on their controllers with coronavirus around. So uncontrolled asthma is a known risk factor for severe disease with coronavirus. And the goal is still to control asthma per the usual recommendations. So the author said there's no recommendations to stop taking or avoid prescribing oral steroids for an acute asthma attack. They also recommend that children who are taking inhaled steroids, antihistamines, bronchodilators, and leukotriene receptor antagonists should continue to take them because they aren't hypothesized to increase the risk of COVID-19 disease. So all of this, the case series of the pediatric inflammatory multisystem disease, COVID toes, really lack of FDA approved antivirals shows that we need better pediatric data. So members of the Pediatric Infectious Disease Society from St. Jude and other children's hospitals across the country have developed a pediatric COVID-19 US registry. And this is where we, as an institution, we are actively entering patient data into this pediatric registry. And we have IRB approval to do this. So if you know of patients, pediatric patients less than the age of 21, it would be wonderful if you could send us a message saying you know of a patient, and then we can contact you to get their information from Epic and share it in the database ourselves. So I want to show you some preliminary data so far from this registry. Right now, there are 88 participating institutions around the country. 703 patients have been reported, and more registry entries have been started but not completed yet. Out of these 703 patients, there were 662 general pediatric patients reported, 2 stem cell transplant recipients, and then 39 immunocompromised patients. The exact definition of immunocompromised is not clear yet from their live updated screen, but I think it will be clear when people start mining the data. The median age at diagnosis for all these patients was 12 years old. All right, so now I want to talk a little bit about the outcomes that this registry has shown so far for these US pediatric patients. Of the general pediatrics patients, 662 of them, 23% were hospitalized in the first 7 days of diagnosis. In the immunocompromised pediatric group of 39 patients, 50% of them were hospitalized within the first 7 days of diagnosis. The ICU admission rate within the first 7 days of diagnosis was double in the immunocompromised group compared with the general pediatrics group, 7% and 13%. And the vast majority of these children were still alive at 7 days post-diagnosis. So 99.5% for the general pediatrics group and 100% of the immunocompromised group. Other outcomes, such as alive at 28 days post-diagnosis, were not immediately available on their live updated registry. And I encourage you all to look at the link down there and look at the registry yourselves because they update it every Monday, Wednesday, and Friday with new cases that are reported. And that's pedscovid19registry.com. All right, so now I want to move on to a topic that I think will bring up a lot of questions. So how do we talk about controlling infection in pediatric specific settings? So delivery room and the newborn nursery, school and childcare centers, childcare programs that are currently open with coronavirus circulating in the community, and breastfeeding moms, and then using masks in pediatric patients. So the delivery room management right now, the recommendations are that when people enter the delivery room to take care of the newborn, they should use airborne droplet and contact precaution level PPE, because it's likely that taking care of the infant with a suctioning and perhaps positive pressure ventilation will generate aerosols. And this is until the mom has her test back or if she tests negative. Um, Maternal and newborn separation is recommended until the mom is known as negative, SARS-CoV-2 negative. And we think this will help minimize the risk of postnatal infant infection from maternal respiratory secretions. We think this separation may benefit moms really who have more serious illness, and this definitely needs to be discussed with the mother prior to delivery because I know this is a big concern for mothers who are delivering during this pandemic. So if a mom tests positive and they are temporarily separated and the newborn is admitted to the newborn nursery, it's recommended to bathe the baby as soon as possible to remove the virus on skin surfaces rather than delaying baby bathing like we typically do after delivery. If the infant needs aerosol generating procedures, again, use airborne isolation until the baby's tested itself. If hospital workflow is not set up to really enable separating mother and infant, or the mother really is doing clinically well and really does not want to be separated from her infant, the mother should use preventative precautions like using a mask, breast and hand hygiene. And there are recommendations really are that the mother should try and stay 6 feet away from the baby unless doing things like diapering or breastfeeding the baby. Newborn viral testing is recommended with a nasopharyngeal swab with the PCR test at 24 hours. And because that can sometimes be negative, repeating it at 48 hours of age. And I know some hospitals are just recommending the 48-hour of age one because the first one can be negative, and that is fine. When these newborns go home from the hospital, infants that test positive for coronavirus should be discharged on a case-by-case basis. And these infants really should be followed frequently through 14 days after birth, and this can be through telehealth. Caretakers should use masks, glove, and hand hygiene when taking care of these infants. For infants that test negative, um, they should go home and be cared for by a non-infected caregiver, or mom should use a mask and hand hygiene until she has been afebrile for 72 hours and has at least 7 days since her symptoms first appeared. The other alternative is that mom can get PCR tested and can have a negative PCR test. For infants that are managed in the NICU and moms wanting to visit, the mom should have resolution of fever for 72 hours and improvement in respiratory symptoms and negative PCR tests. This is a little bit more stringent than in the outpatient home setting. And these guidelines were developed by the American Academy of Pediatrics and are available online for anybody to take a look at. I think a big question on everybody's mind right now is when can school start and how can we do this safely? And this is a key question for us and for people at the NIH. So there was recently an editorial on this in a top tier pediatric journal, and the questions were, does a low percentage of infected kids reflect lower susceptibility to infection in kids, or is it a higher asymptomatic rate? We don't know the answer to this. And figuring out the answer to this, I think, is really going to help us understand whether schools will be grounds for transmission of coronavirus. We also don't know how common these late manifestations of disease, like the pediatric multisystem inflammatory syndrome, are in children. So a recent study by the NIH is looking to help solve this question. And they are using children who are already enrolled in other respiratory virus studies across the country to start screening them for coronavirus testing using that same clinical trial workflow. And hopefully in a couple months, we will have answers to this before the fall rolls around when we have to figure out whether to open schools for the 2020 fall semester. So in the interim, the CDC has developed recommendations for how schools can possibly be open safely and how to minimize transmission among children and between children and the adults in the community. And they have three different scenarios. So they have one scenario where they have guidelines on what to do if there's a confirmed person with coronavirus in the building. Another scenario for how to have school when there's no community spread. And another scenario for how to have school when there's minimal to moderate or substantial community spread. I'll be talking a little bit about each of these and inserting some American Academy of Pediatrics specific recommendations in with the CDC recommendations here. So in a scenario where there is an infected person in the building, they recommend closing school and dismissing students and workers for potentially a short time, but durations should be discussed with local health officials. Obviously, health officials need to be notified right away because COVID-19 is still a reportable infection. It's important to maintain confidentiality of the infected student or staff member. And then areas where the infected individual was, those need to be disinfected. And then they work in tracing contacts from that infected person and working with local health officials to talk about isolating persons who came in contact with them. It's also important to ensure continuity of education, meal programs, and essential medical and social services during this time, which we are all experiencing right now. So in a scenario where there is no community spread of coronavirus, the schools are expected to be open, uh, but they say in the document that schools should not be expected to screen students or staff to identify cases of COVID-19. Their job is to educate students, but not to perform public health duties. That should really fall to local health officials, so they need to work very closely together. So school will look very different in this scenario. So there will be posters around school that talk about good hand washing procedures, how to cover your cough, how to cover your sneeze. They also highlight that it's really important to share information between the absenteeism rates in school with local health officials so they can really have a jump on what's happening on the school level when kids start missing school more than the usual amount. And the AAP recommends discouraging the use of perfect attendance awards and incentives. And I think this is key during this time because I know these are big things in elementary school, a perfect attendance award. But if you have a runny nose and cough, you do not want to be sending your child to school during that time. They also talk about frequently cleaning touch surfaces like keyboards and desks, and then definitely having sick students and staff stay home. And they also talked about how to establish procedures for someone who becomes sick at school. So in most schools, there's usually a single office where those children go to. So anybody with a scraped nose or a scraped knee to someone who has a new cough or runny nose or a new fever at school get combined together. They talked about developing alternative locations for that. So students with respiratory illness go to one place, and then students who have other injuries that need band-aids or medications from home go to a different place. So we try and limit the spread of coronavirus in schools. So this is the really tricky part. How do you have schools run if there's mild to moderate or substantial community spread? Um, so in all of them, they recommend coordinating with local health officials. Um, in the case of substantial community spread, there's likely to be extended school dismissals like we're experiencing right now. Um, with mild to or minimal to moderate spread, they recommend really modifying the school day. So canceling large gatherings, canceling pep rallies, somehow modifying classes that have close contact like gym or music, and have those teachers that teach those special classes rotate to each of the individual classrooms. Increasing space between the student desks and having the students sit in the same desk all day rather than rotate between desks. Figuring out if there's a way to stagger arrival and dismissal times so fewer students are congregating together on the playground. Um, they also talk about limiting non-essential visitors, so school volunteers and people that go into, um, you know, classroom classroom parents or going in to help children how to read. Those would have to be really limited. And they also recommend considering limiting cross-school transfers. So if kids are bused from one school to another one for a specific activity, those activities should be reconsidered. So other school considerations that the AAP specifically talks about are annual school health requirements. So right now, they said it would be good to be flexible and provide extensions to required annual paperwork that children have to submit before going to school in the fall, because sometimes it's hard to get to the pediatrician or your family medicine doctor to get the required annual to go to school, but still to prioritize immunization so kids don't fall behind. And this is really, really critical during this time because we're starting to see this. Students with disabilities, um, uh, during this time, many of these evaluations have sort of been put on hold. And so the AAP says schools can expect to see a backlog of evaluations, and they need to figure out how to get new children evaluated and other children reevaluated during this time. And they said perhaps prioritize these new referrals over the reevaluations. And then considering really high-risk populations. So is there a role for continuing home learning for children who have mechanical ventilation or children with tracheostomies during this time? I think that's definitely up to the individual situation here. So another big question that people have is, well, both parents work and we need to send our kids to daycare because there isn't another option for us both to work. It's not possible. And definitely there are some childcare centers who are open to essential personnel, or some childcare centers who are now starting to take precautions to try and limit the spread of coronavirus so we can have a workforce. So in this situation, there are recommendations to try and limit the spread of coronavirus in this setting. They talk about keeping each group of children in a separate room. So in some daycare centers, there may be a music class that's in a center shared room. They recommend, again, having the music teacher or some other teacher rotate to each group separately. They talk about spacing out cribs and mats as much as possible or putting them head to toe so you don't have two heads within a foot of each other sleeping. Staggering playground time, so it's one classroom at a time on the playground. Um, Considering curbside or staggered drop-off and pickup of children, where people are actually talking about having the daycare workers run out to the car, pick up the children, and bring them inside rather than parents come in and drop everything off. Again, having administrative staff telework from home, not using toys that can't be cleaned and sanitized, avoiding family-style meals and snack time and common serving utensils. And I know this is question for daycare facilities because many times there's a common snack bowl in the middle and they get to practice fine motor skills by using the tongs to pick up snacks and bring them back to their plates, but I think this will have to be reconsidered. Daily health checks are definitely going to occur, so they recommend screening children upon arrival for fever. So this is where the CDC and AAP differ just a little bit. The CDC says, they could just ask about a history of fever, and the AAP recommended that the daycare actually do a real temperature check on the children. They should also be asked about other signs of illness. And I think key in this is that people ask about books. Well, books you can't wash, are they okay? And looking at books from other infection control procedures, children's books aren't considered high risk for transmission, so you can keep sharing those and not have to sanitize paper books. So masks for children are recommended for children who are over 2 years old. And they should be worn where children can't stay 6 feet away from others. So going out to public spaces like the doctor, pharmacy, grocery store, but they don't need to wear a mask if they're, going around outside where there aren't people around or where they can ensure they are at a far distance from other people. And they recommend that younger kids who don't understand physical distancing should should stay home. And definitely kids who can't wear a mask outside should stay home so they don't run up and hug other kids. So I think a big question breastfeeding moms have during this time is, if I am positive, can I transmit COVID-19 to my baby, and how can I my baby safely? So there's no evidence that COVID-19 is transmitted by breast milk. Infected moms or moms under investigation should express breast milk and have a healthy caregiver feed the baby. Or if there's no way to physically distance from mom should wear a mask and wash hands before handling the baby, just to be safe. And with tests coming back faster and faster now, I think that women under investigation should get their test back sooner so they don't have to go through as much of this physical distancing recommendation. So in conclusion, what we think in the pediatric world is that pediatric symptoms are largely milder than adults. Um, Patients with underlying medical conditions are at higher risk, still, just like the adults, but slightly different with their underlying medical conditions. We have some new possible late manifestations that will need updating as we see more and more the mortality rate and affected rate here in the US. Supportive care is still the first line therapy. Um, to understand coronavirus better in our pediatric populations, please notify me or anybody else in our PhD division if you have taken care of patients less than 21 years old who test positive for coronavirus. And then local health officials are working very hard to figure out when it is safe to open up schools and childcare centers. And I know some of you in your local communities maybe asked some of those questions by your local childcare centers and schools. So I hope this helps with that, and then continue working with local health officials to make those decisions. And that is all I have for my talk today. So I'd love to answer some of your questions you may have.
Can you speak to the WHO-China Joint Commission report that showed no documented cases of children transmitting coronavirus within households?
Yes, so that was a study out of China. I don't remember the exact study size or sample size that they looked at, but they had, I think they traced 18 family members and figured out the number of adults that were positive and children that were positive. And from those cases, they thought that every one of the positive pediatric patients had an adult contact who was positive first, and so got it from that adult. I think there's a lot of questions that still arise from that study and from those recommendations. First, I think it's hard to tell in those recommendations, were the adults bringing it home and the children not out in the community sharing virus with each other. So if the adults are the only ones out of the house during the social distancing time, of course they're the ones that are going to bring it home, get sick soon, and spread it to people in their household. I think it's unclear really, if we have children circulating with each other, if they're going to spread to each other and spread to adults. I don't think that question has been answered yet. which is why the NIH wants to do that clinical style or clinical trial looking at respiratory specimens of 2,000 children across the country.
I have a question. Are there recommendations for, if schools and daycares reopen for wearing masks for children over 2 in these situations? Just thinking that probably they aren't always going to maintain 6 feet distance.
Right. So children wearing a mask was not included in any of the childcare or school recommendations. I know we think about it generally. Um, for elementary school age children and definitely daycare age children, I don't see how it would be practical. I don't know any 3-year-old that would wear a mask and keep it on and not just touch their face more. Um, so it may be practical for, walking into the doctor's office, but for wearing all day, I don't think it's going to happen. So I wouldn't recommend it for, an early elementary age school or a daycare child attendee to wear a mask because I don't think it's going to work.
Do you anticipate that COVID testing will be available for children with symptomatic respiratory illness so they can return to school sooner?
Um, yes. So outpatient testing is up to the discretion of the physician. So um, I think any symptomatic child who potentially has a respiratory illness should be tested so we can really understand the epidemiology of this virus more and make public health decisions about keeping household members home. Um, as to whether a child who is still symptomatic and has a negative coronavirus PCR should be allowed to return to school until, if symptoms are still present and ongoing. I don't think the answer to that is going to be yes yet, because we still have, um, you know, a, a, a small false negative rate with the PCR. So I think there has to be a combined PCR and symptoms improving. So no longer febrile and respiratory symptoms improving before going back to school. Has AAP addressed sports, ballet, other environments like that? Um, So I haven't seen specific guidelines from the AAP for that on their coronavirus. It's mainly on schools and child care centers. I think trying to extend from their school and child care centers recommendations, um, anything that requires contact between people of less than 6 feet, they're going to say be very, very careful. And if it's optional, like these sports or music things, perhaps reconsider. Um, I know that's really hard when sports and music things are a way of life for many families. Um, but as much as we can do virtually while we figure out how children transmit virus and how important they are to the transmission, I think we need to hold off starting those activities.
One other question is regarding testing, and the nasopharyngeal test is uncomfortable for adults and for children, maybe more so for a squirming child. Um, we've heard some things that could it be possible, would it be as accurate to do like a nair test or nasal test rather than nasopharyngeal? Do you have any ideas about that?
So those ideas are definitely being tested. Um, The UW Health assay is validated for the nasopharyngeal swabs, not for nares swabs. Um, so we can't do that with this testing yet, but I think we are working on trying to understand that. I think it needs to be addressed in some um, direct head-to-head comparative studies before we say that that's an adequate specimen. I know other people are also looking at saliva tests, so spitting in a tube or doing um, like a swab that you put in the mouth as well, and that would be much more tolerable than an MP swab.
The next question was, sorry if you mentioned this, but are PEDS patients being included in the antibody testing now for asymptomatic individuals in our community?
Right. So the antibody testing that we have at UW Health that just rolled out, pediatric patients can also have that blood drawn. Um, I'm not sure if they were talking about that or if there's a study going on in the community looking at antibody levels. I don't know about that study, but I know here at UW Health you can order antibody testing on pediatric patients. And one scenario where we have recommended that is speaking with our pediatric dermatology colleagues who are seeing some of these cases of COVID toes, recommending that they check serologies both at that visit and in a couple weeks' time to see if they had documented coronavirus infection.
Next question was just bouncing off of that. I think the person was talking about referring to the usual serology testing everyone else was doing and wondering if this be done at AFCH's lab.
Yeah, so it is done at the University Hospital lab. Um, I think it is it's not a send out. I think they have, it's not a test that they developed themselves, but they are using another commercially available test and running it in-house.
Another question was, how many peds COVID cases have we seen in Madison, and how many have been admitted?
Right. So I presented one to you. Right now, we as a pediatric ID division only know of 3 cases. One was a 5-week-old infant. Another infant was, I'll say, 3 months. And then there was another child who was 19 years old. And only the 5-week-old infant was admitted. And that was just for an overnight observation on antibiotics to rule out bacterial sepsis.
Thanks, Dr. Mohr. I know we don't know a ton yet about the inflammatory syndrome that we're hearing about, but do we have any sense of the time course? If there has been, I know some were confirmed positive PCR, some had the positive serology, and some had no documented exposure at all. Do we know when that inflammatory syndrome might occur in the course of their possible exposure? I imagine this is difficult to answer, but
Yeah, so what people think is that it's a late manifestation. So not during the acute phase when you have active replicating virus in your system. So sometime after 2 weeks after you're infected, and I've heard some people talking sort of more maybe a month after so after you're infected. Again, these are people talking from their experience. It's not an actual documented um, uh, case study yet to define that.
And bouncing off of that, is workup and treatment similar to Kawasaki for PMIS?
Yes, it is. So in the Italian retrospective cohort that I presented, all the children were treated with IVIG, and just the recalcitrant ones required steroids, just like we would think about with Kawasaki disease. Um, some of the children required pressors, the ones that had the shock syndrome. Otherwise, it was very similar.
But if anyone has questions, please feel free to email or in-basket message Dr. Mohr or any of the PEDS ID colleagues, particularly if you have any pediatric patients with positive COVID, although I have a feeling you'll find out about them as well, Dr. Mohr. But thank you again so much for teaching us and for answering our questions.
Yeah. Oh, I um, I got a question from somebody, not reported in the general comments, about do you want reports of COVID toe cases? And I just wanted to reply, if the patient has positive coronavirus testing, yes, absolutely. You could also just message me privately because I think our pediatric dermatologists are trying to put in a series of COVID toes and really understand what the prevalence of coronavirus infection was in that group. So feel free to message me. Thank you, everyone. These were great questions that you had.